And welcome to today's webinar about Chimeric antigen receptor or CAR T cell therapy and bispecific antibodies. And we're going to talk today about new frontiers for myositis treatment. My name's Jane Myles. I'm a member of TMA's board of directors and I've worked in drug development a really long time. But I love working with the Myositis Association, which was founded in 1993 and has the mission to improve the lives of those affected by myositis, to fund innovative research, and to increase myositis awareness and advocacy. So that's the hat I'm wearing today. Our webinars are a source of education for anyone who's facing this challenging diagnosis. It could be a patient, it could be a family member, it could be a friend. And I want you to know we're recording the webinar and it will be available on TMA's YouTube channel next month. If you have a second, just drop your location into the chat so we know where you're calling in from. I'm calling from San Francisco, but I brought my special Johns Hopkins mug today in honor of Dr. Konig. And also, I want you to know that you can ask any questions you want about CAR T cell therapy and bispecific antibodies today. But if we have questions that aren't about that topic, I would say direct those to the next Ask the Expert webinar, which will be held on the 28th of March. So it's my pleasure. Well, I'm going to introduce Dr. Konig, but before I do that, here's how we're going to make this work. First, I'll introduce Dr. Konig. Then he's going to do a little bit of science to set expectations, help everyone understand what exactly are we talking about in terms of these amazing products. How do they get built? Where do they go? But we're not going to go too deep on slides. Somewhere around, I don't know, 15 or 20 minutes into this, Dr. Konig and I are going to switch to more of a fireside conversation and have a lot of questions that we've talked through already around some of the questions that we think patients and their families have about these therapies, and we'll be embedding your questions as we see them. So it is my pleasure to introduce Dr. Max Konig. He is an assistant professor of medicine in the Division of Rheumatology and the director of cellular therapy program in autoimmunity in the Department of Medicine at Johns Hopkins University. Could be the longest title I've ever seen. And he also runs a special lab called the Konig Lab, which you might know. His clinical interests lie in treating with patients with systemic autoimmune diseases, including myositis, scleroderma, lupus, vasculitis, and inflammatory arthritis. Now, the cool thing to me, because I'm a pharmacologist once upon a time, is that the things that he's building in his lab are things I only dreamt of when I was in grad school, but he's making them real. So, like I mentioned, we're not going to go too deep in the science. I would refer you back to his webinar or his presentation from the International Annual Patient Conference last September. It's on YouTube. We'll drop the link in. So if you want to see all the slides that he talked about so beautifully there, check out that YouTube video. So thank you so much, Dr. Konig. We're really delighted that you're here.
Jane, thank you so much for having me. This must have been probably the nicest introduction I've ever received. And I'm really honored to be here. You know, it's one of the things that started to get me really passionate about, you know, starting a lab that focuses on immunoengineering and on building better therapies for patients is the patient, of course, right? And we have always seen that over the decades of making substantial improvements to the health of our patients, you know, there are two fundamental frustrations that we're always facing, right? We can't get full control of the disease in some cases, and in other cases, we have an increased risk of infection and brings patients back into the hospital. And really, this is a huge opportunity at this point to go to the next step and, you know, maybe from the get-go start to build therapies that can do both getting control of a disease and not increasing the risk of infection. So I'm really, really glad that I have a chance to be here. that there are patients that are willing to come. I see a lot of activity in the chat, in the Q&A, so that gets me excited. And my goal today is not to teach you everything. My goal is for you to have a chance to ask questions, to maybe give you a little bit of more of an understanding of what we actually talk about when we talk about cell engineering, CAR T cells, and bispecific antibodies, because it's a whole new host and whole new world of therapies, and confusing both for the physicians. So I can only imagine how confusing it is for the patients. So as Jane said, I'm going to give you a couple of slides, hopefully not too long, but enough that we have a nice basis for a fireside chat discussion. And my goal in these slides is to just get you acquainted with some of the verbiage that we're using when we're describing these drugs, with some of the early data that really shows the promise of these drugs, but also gives you a rough idea of what we're actually thinking about when these drugs are administered. And you've probably already learned that this is much more complex of an endeavor than with a conventional therapy that you may have received for myositis. So to ground us a little bit, where are we in history? I find that's always incredibly fascinating. And the history of rheumatology and treatments in rheumatology is not that long. But over the past 100 years, I hope to show you that we have made leaps and bounds a few times. And it happens to be that happens every 20 to 30 years. That seems to be the natural cycle of making huge jumps and leaps in innovation in terms of therapies for autoimmune diseases and also for myositis. So remember, just 100 years ago, we probably wouldn't have recognized the disease, but even if we have recognized the disease as myositis, there is a good chance that we couldn't have done anything meaningful, right? That really changed in the 1950s, where many rheumatic diseases now were able to be treated with glucocorticoids, prednisone, prednisolone, methylprednisolone. You're familiar with these drugs. And that really changed the game, right? Patients with rheumatoid arthritis who were bedbound could get up again. And these drugs are still used today. They're incredibly potent, but they come at a high risk of morbidity, complications, long-term and short-term. Then came the era of DMARDs, where we're starting to use drugs that were borrowed from oncology at much lower doses, like methotrexate. Later, we used drugs like mycophenolate, drugs that you're probably also familiar with now. And then we're living in the middle of the biologics era, where we use monoclonal antibodies. Think about drugs that are infused, like rituximab that targets B cells, or specific cytokine inhibitors that are maybe less commonly used in myositis, but they are used after all. And now we're at the verge of, the next big revolution. And if we do it right, it might be the last revolution that we need. And that's the revolution of immune effector cell therapy. And for the first time, we're not using a small drug or an antibody, but we are engineering immune cells themselves or redirecting them to become the actual therapies. We're talking about living drugs. And you will see that this has a transformative potential. So where did this start? CAR T cells have been used successfully for much longer than a decade in immuno-oncology, in cancer. And they're incredibly potent to treat B-cell cancers, lymphomas, myelomas. It was always thought that these are too toxic to use to patients with autoimmune diseases, but the potential was always apparent. If you can treat a patient with a B-cell lymphoma and potentially cure a patient with a B-cell lymphoma, why wouldn't you be able to have transformative treatment responses for patients with autoimmune diseases that are driven by B cells? The only
Dr. Konig,
difference.
I'm interrupting you only because we can't see your slides advancing.
Oh, no. Oh,
We can see them on the side, but they're just not advancing as you're speaking.
Oh, that's unfortunate.
There you go. That's it. You got it. Thank you.
Yeah, I exited out, but I'm going to advance hopefully like this. Does that work? Improvising. Okay. I apologize for that. So I don't know what you saw. But what I'm going to continue, and we will have plenty of time to discuss if anything was left without visualization. So what does it mean to engineer a immune effector cell, a T cell? It means that you're taking a patient's own immune cells, including the ones that are actually bad in a patient with myositis because they can cause disease. But you're taking the T cell and you're making them a drug. And you do this by integrating specific immune receptors called a CAR. You can see this here. Down here is a T cell. In here, in the cell membrane, sits the CAR. And on the top here, this is your target cell. This is the B cell you want to actually eliminate. B cells being sources of autoantibodies in myositis. So these are actually sources of the things that drive disease. And CAR T cells that are able to be designed to specifically bind to B cells can create this cross-linking between the T cell and B cell. It's called the immune synapse. And the immune synapse is the metaphorical kiss of death that the T cell is able to give the target cell. And during this interaction, the T cell gets activated, it secretes a bunch of toxic proteins, and the toxic proteins will directly affect the cell that it binds, and that is the B cell, but it will diffuse out and it will not be able to be enough to kill other cells in the vicinity. So in myositis, you are aware that there are many, many different kinds, but in most of the forms of myositis that we understand today, there are actually autoantibodies. We use them to diagnose the disease, and sometimes they're right in the name. You might be familiar that somebody says they have anti-Jo1 antisynthetase syndrome. So the antibody that was discovered that's unique to the disease is typically already in the name, and there's enough evidence to suggest that these antibodies are directly pathogenic. So if we could directly eliminate B cells that make these antibodies that then cause muscle damage, lung damage, skin inflammation, we could potentially get rid of the disease altogether. So CAR T cells are a way to do that. And there are two major ways nowadays to make CAR T cells. And I'm mentioning both because as you are thinking about this field, and you might be looking for clinical trials, and you're going to be realizing that there's a lot of complicated verbiage associated with them, be aware that there are two major ways of doing this. The conventional way that is FDA approved for cancer at the moment is the generation of a living drug from the patient's own blood. So how does it work? If you wanted to undergo CAR T cell therapy, you would go to a specialized center where they can do something called apheresis. This is the collection of blood, particularly of white blood cells that contain T cells, in amounts sufficient enough to allow us to engineer living drugs. And think about how different that is from anything that you're familiar with, something that's off the shelf, a antibody, a small drug in a pill. Here you're actually trying to get T cells. They're shipped into an engineering facility or lab. In the lab, the T cells are isolated. These are the natural killers. They're massively active, and that allows them now to be engineered. The engineering will now introduce the CAR construct, a genetic sequence, into the genome CAR T cell. The T cell becomes a CAR T cell, and now with the activation, you're able to generate large amounts of these CAR T cells as they proliferate and increase in number. They're then purified, sent back to the hospital, and in the hospital, two things happen. One, the patient is going to be prepared for CAR T cell therapy. This is something that is referred to as lymphodepletion or conditioning therapy. It is something that is coming from immuno-oncology, where it has been found that it's incredibly important for CAR T cells to work effectively. And essentially, it is the infusion of cytotoxic drugs like cyclophosphamide, something we also sometimes use in rheumatology, and fludarabine a few days prior to cell infusion. That will bring cell counts down in the patient, and it will create the environment of CAR T cells that supports them to expand. Then the patient will get the own engineered cells reinfused. And once they're reinfused, they hopefully take a hold in the patient, they massively expand, and they start to kill the target B cells. This can be a time of stress, because CAR T cells, as they expand and get activated, they secrete a lot of cytokines, molecules that cause inflammation, and that leads to some complications of CAR T cell therapy. There is a second way of making CAR T cells, and this is starting to be appreciated more and more as maybe the way to do it if we want to bring these therapies to a large number of patients. And that is, instead of making autologous CAR T cells, these are coming from the patient, him or herself, they're allogeneic, which means other derived. So these CAR T cells are not coming from you. They would be coming from a healthy donor. Think of the same process. You're collecting T cells from a healthy donor in large amounts. You're isolating them, but instead of doing one isolation and one engineering step for each individual patient, you're now doing this upfront, and you might end up with 400 or more individual doses of CAR T cells that now can be infused into the patient, who does not need to undergo apheresis. There are a couple of things that are critical here. If you did this without any further engineering, the cells would be immediately rejected. So there are a couple of engineering tricks that need to happen up front. These allogeneic CAR T cells can then be infused into the patient. They still need conditioning therapy, that preparational use of Cytoxan, cyclophosphamide, and fludarabine. But you can imagine that if something is off the shelf, can be available immediately, and can be administered quickly without having to undergo all the efforts of apheresis and cell engineering for the patient, this could dramatically reduce effort. So I mentioned conditioning therapy. I just want you to be familiar with that term. It's often used interchangeably. I use the term conditioning therapy. Other people use the term lymphodepletion, referring to the fact that you're bringing down immune cell counts in the patients. That's the same thing. And it's typically at the moment, meaning you're getting an infusion of cyclophosphamide and fludarabine typically over 3 days. And that has some side effects. These are very potent drugs that lower cell counts, and that will invariably increase the risk of infection. So keep in mind that a short-term consequence and risk of CAR T cell therapy when conditioning therapy or lymphodepletion is used is always that the cell counts will dramatically drop, including neutrophils, and that creates a real period of risk for patient where we need to dramatically prophylax them by giving upfront antibacterial drugs, antifungal drugs, antiviral drugs, so we're reducing the risk of infection. After a few weeks, the cell counts come back up, and hopefully at that time, you will be only left with the depleted B cells, but you don't have that early downside of lymphodepletion. So does it work in myositis? I'm just going to give you a quick flavor. Here is one of the first patients treated. This is a patient with anti-synthetase syndrome that had anti-Jo1 antibodies. And this patient was refractory or partially refractory to many of the drugs that you might be familiar with. Rituximab, a B-cell depleting antibody, tacrolimus, IVIG, even received some cyclophosphamide. Now, when the patient received CAR T cells, the CK levels, the muscle enzymes, dramatically came back to normal levels. You can see that that was mirrored by also a loss of autoantibody levels, becoming completely undetectable, and many, many metrics that suggest that the patient got better. The fibrosis or inflammation in the lung got better. The muscle got much better. So different to therapies that we would conventionally have in our armamentarium that work in many patients really well, but in some patients fail to achieve disease remission. This is a real step up. Patient can now be treated, and some of them might go into complete disease remission. Think of it looking like the disease is no longer there. And this can be sustained. This might be going up after a few years. We're early in the time. We don't know how long it lasts, but it might last a long time. And this is replicated in other forms of myositis. I'm showing you one more example here, which is a patient with necrotizing myopathy and anti-SRP antibodies who received an allogeneic CD19 CAR T cell. So this is the one that's off the shelf, that's previously engineered, not coming from the patient itself. And you see the same thing. The muscle inflammation you see in the bright within the muscle, that's the inflammatory signal here, is dramatically reduced over 3 months. And that is mirrored by normalization of CK levels and significant improvement of muscle strength. So the potency in this example is just as high, and a really, really promising signal for both autologous as well as allogeneic CAR T cells. Okay, briefly, what should you be aware of in terms of risk? And we'll discuss that. I'll just mention it quickly here. 3 major things. When T cells are infused and start killing B cells, that's what we want them to do. Eliminate B cell in all tissue niches, not just the peripheral blood, deep in the muscle, in the lymph node, in the bone marrow. T cells will get activated and they will proliferate. And as they proliferate and get activated, they will produce interferon gamma, which then can drive an inflammatory response that we call cytokine release syndrome. And when it involves the brain, we call it ICANS, neurotoxicity syndrome. These are feared complications in cancer. Luckily, in patients with myositis and patients with autoimmune diseases to date, in most cases, the toxicity is much lower in terms of frequency and in terms of severity than in patients with B-cell lymphomas, but it is not zero, and we need to be hyper aware of it. The second is infection, and that's probably the biggest one, because both the conditioning therapy up front that really depletes your neutrophils and your other immune cell lines poses a higher risk of infection. That's why we're prophylaxing. But also in the longer term, as B cells are depleted, vaccine responses are lost, there remains a significant risk of infection that's slightly different than at the beginning. But keep in mind, even though in clinical studies and cases so far, the signal seems to be relatively good, the risk of infection is real. And then in the cancer literature, very hotly debated over the last few months, is the observation that very rarely, somewhere between 1 in 500 to 1 to 2,500 patients can develop a secondary cancer. And this has not been observed in patients with autoimmune diseases or myositis. But we need to be aware that this is a possibility. So we need to be very careful about discussing this with patients and about risk benefit. What do you expect if you undergo CAR T cell therapy? Well, you're going to get conditioning therapy, as we discussed. You're going to get the cells infused. That happens only once. And that starts a period where we need to start to prophylax the patient. And you can see here what is typically done. There is an antimicrobial, there's an antiviral, there's an antifungal, and then PGP prophylaxis, which a lot of patients are on already. And this is used at different times throughout the treatment course, but this is preventing a higher risk of infection. I want to tell you about one more thing before we start discussing, and this is chewing gum. And I want you to just keep this image in mind because I'm going to tell you about another approach that doesn't involve cell engineering, but can achieve probably the same. And that is called bispecific T-cell engaging antibodies. Very, very long word, bispecific antibodies. Think of it as a molecular glue that can be infused into a patient and that brings together a target cell like a B cell and a T cell, the killer cell, without needing any cell engineering. So how does it work? You're familiar with monoclonal antibodies like rituximab that directly bind to the B cell to deplete the B cell. Now imagine you had a version of an antibody that has two arms. One arm of this engineered protein grabs any T cell in the body. The other arm grabs the B cell that you want to target. And through that molecular glue, the two cells are brought into proximity. They're forced into proximity. And that forced proximity activates the T cell. And now the T cell starts to kill the other cell that's bound. This is basically achieving the same thing as a CAR T cell, but without requiring any cell engineering. And in oncology, this has been used for more than a decade to treat B cell cancers, and they are almost as efficacious as CAR T cells. So what's the benefit? Why would we want to think about this? You don't need to engineer anything. There is immediate availability because it's off the shelf. It's a protein, just like any monoclonal antibody. And it can be very easily, repeatedly given. So does it work? Very little data in autoimmune diseases, but there's an inkling, including in myositis, that these can be quite potent. In this case, we're targeting something else. We're targeting a B cell surface molecule that's not CD19, but BCMA. BCMA stands for B cell maturation antigen. Think of it as different flavors of ice cream. You can target the B cell in different ways, but depending on what you choose to target, you target slightly different B cell subsets. Some are very differentiated, some are earlier in the process. These therapies are highly efficacious, but if you target BCMA, we're starting to appreciate, as we would based on the experience in cancer, that we see higher risks of infection. And one of the reasons that might be the case is that BCMA is expressed on many plasma cells that make vaccine responses, plasma cells that pump out large amounts of antibody. And what you can see here, even though these patients respond dramatically well, you see also that the total immunoglobulin level, antibody levels drop. So that poses an increased risk of infection. And in fact, in this case, patients would be substituted with immunoglobulin as a prophylaxis to bring these antibody levels back up. And that is IVIG that many of you are familiar with. So before we end, last slide, second to last slide, benefits and risks. What's the difference between bispecific T-cell engagers and CAR T-cells? What are the benefits? A bispecific doesn't require any cell engineering or any production individualized to the patient. It's off the shelf. There's no lead time. Because you're not requiring cells to engraft in the patient, you don't need conditioning therapy, the cyclophosphamide, the fludarabine. So the risk of infection is already lower. In cancer, the risk of cytokine-related toxicities, CRS and ICANS, is also slightly lower, though that is marginal. And an additional benefit might be, well, if you have poor renal function, you might not be able to get CAR T cells because the conditioning therapy, particularly the fludarabine, requires certain renal function. The limitation should not exist for T cell engagers. So benefits of CAR T cells, proven to be one-time administration and in some cases long-term disease remission, yet has to be proven with bispecifics, but both will have a role in the treatment of our patients. So where do I start if you want to think about CAR T cell trials? Very difficult. We'll talk more about it. But a good start, just to get a sense what's around you, is to go to clinicaltrials.gov. There you can put in a disease, myositis, some other thing to look for. It could be CAR, it could be CAR T cell. You could type in bispecific antibody. And then where do you live? And you have like a slider here, how far from your location that is. And we'll show you some trials that are actively recruiting on CAR T cells. None of this is perfect, but it is a start to have a discussion. And I probably spoke much longer than I wanted to, so I apologize to Jane, but hopefully we can have a great back and forth discussion still.
I think that was perfect, really, because you set up a lot of the questions that we talked about already. Um, I'm going to go back to the trial finding step, having worked in patient recruitment and drug development a long time. It's not so easy for patients to find trials. And I'm just going to make a call out. Clinicaltrials.gov is a helpful source. Wasn't built for patient recruitment. But TMA has some great resources too about trials that are open, and I would recommend that you work with our staff if you have questions about that. But let's go back to the big picture. So you've been on clinicaltrials.gov and you found something that might be interesting, but I bet you and your colleagues get a lot of calls about trial slots. So, what would you tell a patient to expect when they start that initial screening process from a timeline perspective, maybe from who needs to be involved in the discussion, and then what do you really need to think about in addition to risk benefits if you're going to go into a trial like this?
Yeah. There's a lot of nuance to all of these things. So I think we all recognize how challenging it is, hearing about all of these exciting therapies to actually identify trials. And it's a different landscape than before because these trials require certain infrastructure and a lot of infrastructure that is typically at the moment only present at large academic institutions to be able to actually give the drug, monitor the patient, and manage the complexity of it. The hope is then in a decade or so, when we're knowing better how to do this, it will become much easier. But for now, everything that is done in the setting of clinical trials because not a single CAR T cell is FDA approved. So you will not find it that a physician anywhere would be able to, petition the insurance to get CAR T cells. It needs to happen in the setting of clinical trials. And clinical trials, particularly the ones that we're currently actively pursuing, are phase 1, in rare cases, phase 1-2 trials. What that means, they're very early. The goal of that trial is actually to make sure it's safe, right? And that means that these trials try to recruit very few patients. Despite that, it's actually hard to recruit exactly the patient need to go in there. So there is a limited amount of bandwidth to actually treat patients. And there are certain rules that need to be followed that are set up and negotiated between the company who has an interest to recruit many patients and make sure that they see that their product works, and the FDA, whose goal is to make sure that it's safe first, right? And in this back and forth, there are specific guardrails that exist, and it often leads currently to the fact that many, many patients are excluded, right? You need to have certain things that make you eligible, called an inclusion criteria. You need to have features that are not present, exclusion criteria, to even allow you to be screened. And that is a large barrier still. I'm seeing that over the past year, the FDA is very, very thoughtful about liberalizing that as more data is coming in about safety, and really working with both physicians and with industry to trying to make these protocols more open to allow more patients that are really deserving to come in. But I would say upfront, it's very hard to currently get CAR T cells because they're very restricted. They are tailored to the patients that have active and still severe disease, because the first goal is to make sure we're not over treating. We're doing it in patients that absolutely need the drug and where we can have the biggest impact. So how do you get into trials? I think that your local rheumatologists need to be a liaison for that. And I think associations like the Myositis Association need to be the second foot here, because it is absolutely overwhelming for a patient and probably very frustrating. If you are close or seen at an institution, a larger academic institution, your local physician will be able to tell you, is there a CAR T-cell trial that locally connect you with who's running the trial at that institution. But many patients are not at large academic institution, and here it becomes much harder. And it becomes harder for two reasons. One, you know, actually even getting on somebody's radar, I think the local physician is the best liaison for that. So the rheumatologist will have a rough idea whether a patient could potentially qualify or is suitable. And ideally, that rheumatologist refers to the local principal investigator and is then already a go-to person to ask some follow-up questions. Because when I get a referral directly, and I do, and I respond, but getting the critical information about the illness, the duration of the illness, lab values that allow me to make a distinction whether the patient would be suitable or not based on the very strong constraints is often hard to do. So I think the local rheumatologist is your quarterback. And then in terms of identifying suitable sites somewhere in your vicinity, clinicaltrials.gov as a search. But frankly, the Myositis Association, and we were chatting, Jane, I think we need to come up with easier ways to do that, and it takes time.
We're working on that.
I
And
am sure.
I've got some, this is a passion of mine. So I agree with everything you said. And I would also say patients need to be their own advocate. So partnering with your rheumatologist and really making it clear your level of commitment and interest is critically important. And for those of you who've never had the pleasure of reading a clinical trial protocol, the last one I worked on actually had 70 inclusion and exclusion criteria, which is probably about the same as a CAR T cell therapy trial right now in phase 1 in autoimmune disease. I'm only guessing. So sometimes I describe it like, where's Waldo? So you talked a little bit about the restrictive nature of clinical trials right now, and we have a lot of questions from the audience. Like, okay, so it's getting tested in dermatomyositis. What about IBM? Could it work there? What if you are refractory to Rituxan? What if you have tissue damage? Like all of these great questions are coming in. So a little crystal ball. Where do you think we're going to see this go as we get more safety data and the FDA is advocating for a wider population?
Yeah. So it's really hard to tell you in general who qualifies, right, in what disease, because there's a plethora of trials. Every trial is slightly different. If the trial was started a year ago, it looks very different than now because the FDA has changed, in many cases, the tone. But I'll tell you in general, most forms of myositis probably, in theory, qualify. They come in different flavors, but there are B-cell mediated autoimmune diseases, and whether it's antisynthetase syndrome, dermatomyositis, some hopefully don't use the term polymyositis, immune necrotizing myopathy. Those are generally populations that would be eligible for a trial. I meant two things I didn't mention. Overlap syndromes, which is a huge challenge at the moment and is very common, right? But even the co-occurrence of a second autoimmune disease sometimes lets people fall out, or in many cases, people would fall out of the trial because they're written in a very, very purist way. So that is one challenge, and you know, we're advocating as best we can, both with the FDA as well as, you know, when new trials are written, that hopefully we can include it, but it's challenging, right? Because you're measuring then responses maybe of scleroderma features and myositis features. The second part that is really challenging, and I know there are a lot of people probably here in the webinar inclusion body myositis, right? And it is, I think everybody is aware that there is a huge gap in treatment opportunity and availability between inclusion body myositis and what we have in other forms of myositis. And, you know, I think it's a frustration in the field as inclusion body myositis, even though there are some autoantibodies, seems to follow different rules in terms of treatment response. I think we will see probably in the future treatments for inclusion body myositis. I'm not sure that, you know, B-cell targeted therapies are going to be the answer as current CAR T-cell therapies are. But I think we'll start to see other therapies targeting T-cells and other mechanisms in that. But be aware that I think we're probably a decade or more behind in inclusion body myositis. So you will not find many opportunities for inclusion body myositis currently, if any. So
Yet.
yeah.
And that's the crystal ball part of science in a way. I have two questions. One's coming from the audience. One is something that you provoked for me from watching your YouTube video. So I'll start with the second first. You talked about the potential risk of cancer from CAR T treatment, but can you talk a little bit more? Like, let's say you have the treatment and your B cells come back. What are we going to be monitoring, and how is that patient actually going to be treated after the treatment? What do you need to do?
The real goal of CAR T-cell therapy is to achieve something that some have called immune reset. And sometimes we talk about deep B-cell depletion. So what does that mean? Current therapies, even if we use something like rituximab, they're very good at eliminating B cells in the peripheral blood. And when we check typically after we dose a patient, we see that all B cells disappear in the peripheral blood. What we are starting to appreciate is just because you're eliminating something in the blood doesn't mean that the relevant cells are actually eliminated in the relevant tissues, whether it's the muscle or the joint of a patient with rheumatoid arthritis or lymph nodes. That is actually much harder to achieve. And we see a fundamental gap between the therapies there, where a CAR T-cell therapy or a bispecific antibody therapy not only depletes in the peripheral blood, but is actually able to wipe out the B cells in the target tissue, the muscle, the synovium of a patient, the joint of a patient. So that's the fundamental difference. If you're able to eliminate the B cell population everywhere, you are able to force the body to repopulate that B cell population after about 3 months or 4 months, varies a little bit from patient to patient, with completely new cells that are not regenerating from cells that are sitting in lymph nodes and in muscle, but coming from very early B cell populations. And when they arise, there's something unique about them. It's like a blank slate. They have never experienced antigen, have never been activated by antigen before. So they have features. They're not hypermutated. They don't have IgG receptors. They're naive B cells, they're called. And because the memory B cells, the ones that, you know, exist after they have experienced antigen for a long period of time, are wiped out, the B cell compartment doesn't remember that you had myositis, but it also doesn't remember that you have seen certain infections before. But that is fundamentally what we want to achieve. And when you achieve that, you can basically reset the immune system in the B cell compartment. And then the hope is that you don't re-evolve towards myositis. And best case scenario, and that's really the real hope here, is that a patient is treated once, achieves deep B cell depletion, and now when the B cells come back, there's no signs of myositis anymore. And maybe 5 years, 10 years, 20 years down the line, many patients still don't have myositis. They are, for lack of a better word, cured, right? That is what we want to achieve. That's the hope. That's why everybody's so excited. For the first time, it feels like this is achievable, right? So that's the goal. Everything that's shy of this goal is not worth all the effort, right? Not because it's not worth for the individual patient, but because we have other things that could achieve the same, right? Um, and and as we get more and more familiar with how to do this safely and understand the risk benefit better, if we can truly achieve that with certain products, it will become much more widely available, because now all of a sudden, um, it is absolutely clear that if you can achieve long-term disease remission, the risk is worth it, right? It's just the question now currently in clinical trials, how about somebody that could be managed with something else and they might be fine with IVIG or rituximab?
So I'm just disclosing, at first, when this whole idea came up, I was sort of terrified because I lived in the oncology domain of what happened in patients. These patient responses are really very different. And so I think in your presentation in September, you made a comment about how early treatment might be really helpful with these therapies, which isn't necessarily a possibility right now. But how do you think that's going to play out as we conduct these trials?
Yeah, we're living in a strange situation where clearly at the moment, for safety reasons and while we're investigating a product, refractory severe patients are the ones that are going into trials, right? You need to be able to go into an FDA approved trial. You need to have demonstrated that you fail current standard of care, and typically you need to fail 2 therapies or so for a certain amount of time. The um, the evolution of this should not look like that. The evolution of this should look like giving it to patients that haven't accumulated a lot of damage yet, but where we can predict or extrapolate that if we don't get the disease under control, there is going to be a lot of damage, right? Once muscle is a unique situation because muscle tends overall to regenerate well, but the lung does not, right? And other organ systems. So, or the heart does not. So if we can identify patients at risk that are at risk of developing lung fibrosis or myocarditis, or just frankly horrible myositis that over time also leads to disability, those would be ideally treated early, right? But that will need to happen once patients are really once drugs are FDA approved. I think that's an ideal patient population, right? That's where you can really make the impact. And we're seeing this over and over, right? There is reversibility of things that are driven by inflammation. But once you go through that remodeling and fibrosis sets in, there's very little you can do about that at the moment.
It's interesting because even, gosh, when I was diagnosed a long time ago, there was this watch and wait protocol. And now I'd say we like to treat more aggressively earlier. And maybe this is just the next level of potency in terms of earlier treatment when we have the safety data.
Absolutely. And keep in mind that rheumatologists are risk averse. I work a lot with oncologists. They have a very different approach to problems,
Yes,
right?
yes,
It
they
is
do.
they are much more willing to accept certain toxicities, dealing with clearly, diseases that need to be taken very seriously very quickly. That is also true for autoimmune diseases. It's just that traditionally, overall, I think we're much more risk averse and more erring on the side of not causing damage and toxicity. And I think that's overall a little bit shifting. I think fundamentally how we think about it is changing, how the field is changing, thinking
Sure.
about risk is changing. 5 years ago, when I talked to patients about to rheumatologists, right, and others about we should use immunoeffector cells for treatment of autoimmune diseases and build those, there's a good chance you would have been laughed out of the room, right? So times are changing, and I think we're
Yeah.
going to hopefully get to the early patient treatment, as long as we're not worried about other things that might preclude that.
Yeah, in a way, I would say some of what has happened in oncology is trickling over in that earlier, more aggressive treatment is now seen as safe and effective. But they have data, so we have to get data. Let's imagine everything goes perfectly with the data collection,
Mm.
and we get FDA approval. So two questions, very crystal ball questions. One, when do you think the first approval might come? I don't know if you have that answer, and you can say don't know. Second, let's imagine we get a few approvals. What do you think we're going to need to do to shift the insurance providers' thinking around supporting patients to get access to these treatments?
Mhm. Very tough questions. And I don't have a good answer for the first one. Typically it takes a few years. Um, but these trials need to recruit, you need to have enough data, it needs to move from an early trial to later trial stages that require many, many more patients. And we're seeing with these therapies, it's so hard to recruit, and it's very slow and painstakingly slow, that I can't really predict how fast you might actually be able to go for a through a whole phase 2 and phase 3 trial. And I think the way the FDA thinks about approval in the context of cell therapies probably needs to change. So I don't have a clear answer, but extrapolating from oncology, my hope is that in a few years, let it be 5 years, I'm making up the number now, we have FDA approved drugs. But too much variability for me really to pontificate on that. The second part, Paula, can you remind me the second part of the question? I'm blanking right now.
Maybe
Sorry.
there's no point in answering. We'll have to sort out how we help insurance orgs understand the value of these therapies so patients can
Mm,
get access to them.
yes.
That's a question for another day. However,
I'll say that, right? It really depends on what the trials show.
yeah,
My hope is that the trials will show that the majority of patients achieve immune reset and will be able to see that they stay in complete disease, not everybody, but the majority of patients will stay in complete disease remission, and that's sustained. If that's the case, it should be easy for somebody who's smarter than me and has economic minds to actually come up with a formula, right? To identify, disability, loss of productivity, cost of current drugs that can't achieve long-term disease remission. And I think you would quickly come to the point where it's cost effective. That said, it's incredibly expensive to get CAR T cell therapies. In the United States, everything is more expensive, but estimates for a FDA approved CAR T cell therapies to actually be administered and patients to go through all of it, including a hospitalization and so on, somewhere between $500,000 and $1 million. So it's not cheap. The hope is that we're going to see something that we have seen with sequencing. When the Human Genome Project was started, right? It cost billions to sequence the genome. Now I can order it and it costs $1,000 or less, right? And the same, I think, under realistic market forces should be true for cell engineering. It will maybe not be as dramatic. It costs a lot to do this engineering. But between allogeneic products, bispecific antibodies that are off the shelf and shouldn't cost anything more than a monoclonal antibody, even if you factor in the need for monitoring and hospitalization, the cost should dramatically come down. So I hope this discussion in a few years will look very different.
and this is where I think that although the FDA plays a very different role, they look at evidence and data. That evidence and data is so strong in these settings, not autoimmunity yet, but in others, that I've heard Dr. Marks, who's the head of the division of FDA that approves these drugs, say the issue we have with democratizing these therapies is an engineering and manufacturing one. So just like you said, when we figure out how to create the library of off-the-shelf therapies, how to first engineering cells, who knew that was even possible? But when that gets to be sort of second nature to us, it will change the cost dynamic a lot.
And Jane, we have mostly talked about CAR T cells. I want to bring it back to the bispecific antibodies because at the moment so much is happening. We're talking about CAR T cells, and the next thing is thrown at us, right? But if you look a little bit over the horizon in rheumatology, we're just repurposing at the moment from oncology. So we can extrapolate what is going to happen. And the bispecifics are remarkable tools. And I would say there are incredibly suitable for our field, for rheumatology. Why is that? As rheumatologists, we do two things well: send patients to infusion centers and injecting drugs sub-Q, right? And those are the two ways you will give a bispecific antibody. And imagine using similar approaches that we're currently using for drugs we're already giving, but the only thing that's different is now we're using them to redirect the patient's own immune system to wipe out the B cells without cell engineering. We don't need to think about risk of malignancy. It's all hypothetical at the moment, right? But I think we need to talk about it when I see patients off the shelf, and in theory should be much cheaper. And once we're starting to be able to do this and get a sense of like what is actually the risk of cytokine toxicities and so on, I think it'll go to the outpatient setting. And once we're able to give these drugs without inpatient monitoring in the outpatient setting and figure out how to do this safely, then all of a sudden, we're really democratizing, because now we can actually start to think using these drugs not only in the most severe refractory patients, but there is going to be bandwidth to give it to moderate disease, severe disease, early disease with bad trajectory, right? And I think that's what makes me most hopeful in the short term, that as we're seeing this influx and excitement about immune effector cell therapies, we're starting to figure out how to do this and how to do this safely and how to do this more easily. And I think when that happens, it's going to be completely transformative, not just for very few patients, but for many.
Well, I can't believe the hour's gone because I could ask you questions for days, but I bet by the time we get to the annual patient conference in September, there'll be a whole bunch new information and data and trials. And so I will be revisiting this, certainly. I want to say thank you so much, Dr. Konig, for spending the time with us today, but also for that work you're doing, the magic, the things that I only dreamt of. So our next webinar is Ask the Expert with Dr. Nicole Voet on March 28th at noon Eastern Time. You can register at the myositis.org site, and the registration link is in the chat. Also, please send your feedback on this webinar. There's a real short survey, and we need to know what's working for you and how to change the content to be most helpful. But it was my absolute pleasure, especially because I got to meet Dr. Konig. Thank you so much.
Jane, thank you for having me, and thank you for everybody who joined the webinar. It's an absolute honor that you're all so interested in this field, and I'm incredibly excited.
Me too. Let's go.